thank you for the opportunity to present and share the results of our survey on the use of the risk calculator, the latest IDF Diabetes in Ramadan risk calculator. And this was our preliminary experience of using this in the last Ramadan of 2021, which was hardly a year ago. I'm presenting this on behalf of our unit. So I think we've heard most elaborately from the first two speakers about how the risk calculator or risk scoring has evolved from the prior guidelines, because this is an important area, as fasting during Ramadan carries very considerable risk for our patients with diabetes. And to risk stratify our patients is very important so that we can actually institute the appropriate strategies to prevent complications. So the prior risk stratification systems of 2010 and 2016 were very broad and not specifically or objectively considering the very many Ramadan-related, disease-related, and patient-related risk variables. So we really applaud the 2021 IDF-DAR practical guidelines for introducing the new risk calculator, which was very explained in so much detail by Professor Bashar in the first lecture just now, where it incorporated all the different risk, 14 risk elements. Yeah, and I won't elaborate so much because we're familiar with that. So this just shows the IDF-DAR guidelines of 2016, which we also had a view from the previous speakers on how it broadly categorized our diabetic patients into these different risk categories. And according to that, those in the high risk and very high risk were recommended not to fast. There were also special populations identified, type 1 diabetes, the elderly and pregnant patients as well, were generally advised not to fast. But we were very well aware that even those with the high degree of risk still continued to fast, and most could do that quite safely. So with the latest IDF-DAR guidelines, which was introduced exactly about a year ago during the DAR conference, the 9th DAR conference in January last year, we realized that this allows more flexibility, very much more objective scoring, more personalized sort of consideration for the different factors contributing. And all these factors having different weightage to the eventual risk score. And these were considered Ramadan-related factors, diabetes-related factors, and also the individual factors, which we've all heard about earlier. And we've also seen how the weightage of each element from the risk factors and how to actually get to the full score, and following this, how this then leads to the risk categorization, and that would also then nicely sort of lead to the general recommendation to fast or against fasting, that we have been clear about. So the objectives of us in our Hospital Putrajaya, which is a tertiary hospital majoring in endocrinology in the heart of Malaysia, was to actually very quickly after the introduction of the new risk stratification and also some training workshops by the IDF-DAR in the Asian region, which followed quite quickly after the introduction of these guidelines in February. So we had just a matter of about 5 or 6 weeks where we could quickly see how these new risk stratifications or scoring could be applied to our Malaysian patients in our outpatient clinics in the few weeks prior to Ramadan. So we wanted to assess the patient's intention to fast with this new risk stratification and how they would accept the recommendations to fast or not to fast. And also how well our doctors, upon being trained in this simple scoring, would accept this new tool. So methodology was, it was basically an observational cross-sectional study in our outpatient diabetes clinics of our hospital. And of course, we included Muslim patients with diabetes attending their follow-up in the 5 weeks prior to the start of Ramadan 2021, which was in the second week of April last year. And this constituted 6 clinic sessions. We have weekly type 2 diabetes clinics and a monthly type 1 diabetes clinic during the period here that is mentioned. So we trained our doctors, we provided them with hard copies of the risk score and taught them how to actually perform the marking and the scoring. So the patient's demographic and diabetes profile were recorded from their electronic medical records, and risk stratification was used, and the patient was then asked with regards to their intention to fast, and this was recorded. And at the end of the study, a survey among the healthcare professionals, the doctors, with regards to how well the risk stratification was actually accepted by having a 6-point Likert scale and also an open-ended question for feedback. So these are part of the results, selected results, not the entire, but we had the opportunity to use the risk scoring for 210 patients in our clinics over that few weeks of period. Their mean age was in their mid-50s, ranging from adolescent of 60 to the elderly of past 80 years old. And as you can see, the male-female divide a little bit more, 60% were female, but largely so, 94% of the patients were type 2 diabetics. And because we are a tertiary clinic, where most of our patients had a long duration of disease, about more than 2/3 had a diabetes duration of more than 10 years. And we've already heard from Dr. Muhammad Hassanin about the impact of duration of disease of diabetes on the decision to fast and the risk during the fasting. We, as a tertiary hospital, there were more that actually were on insulin. Again, 70% were on insulin. And also with regards to glycemic control, a little bit more than half had blood glucose control over the A1C of 7.5%, so not optimal. In terms of glucose lowering medications among our patients, as mentioned already, 70% were insulin treated, and we appreciate from the risk scoring how the different treatments, basically sulfonylureas and insulin, give weightage to the score, more intensive insulin regimens do predispose patients to hypoglycemia, and the weightage for the scoring is higher. So a fair number of our patients were on intensive insulin regimens, about 40%. With regards to those on oral agents, again, these patients with longer duration of disease happen to be on more agents, 2 or more agents if they were on oral agents alone, And we could see in the chart here how the divide among those on insulin, you can see basal bolus being a predominant 40%, premix insulin about 1/3 of the patients, having just a basal insulin only, 1 injection with oral medications making up 15%, and the other 1/3 were different combinations of oral anti-diabetic agents. So when we looked at the patient profile, after we've scored the patients, what we found is that most of the patients in our center, as expected probably, but we didn't realize how high their scores would be, were in the moderate risk as well as the high risk. And you put that together, the 40% had high risk and about 33% had moderate risk. So actually more than about 3/4 or so would be, advised against fasting. Despite that, the overwhelming majority, 9 out of 10 patients, 92%, still intended to fast despite their risk category. And this we already know, from past experience, that even patients from previous risk scoring, even when they were high or moderate risk, would still intend to fast. We had a very small number of type 1 diabetics, only 13 patients, which made it 6%. And they fell, of course, being type 1 and then being on insulin and being exposed to hypo, they all fell into the moderate and high risk group being type 1 with all the other associated factors. Yeah. And interesting to look at as well was that, the insulin use, because those who were on insulin, the more injections that you had, then you fell more into the higher risk category as expected. So insulin actually impacted on their risk category, as you can see here. For those on oral medications, they were largely in the low risk category, but once they had more and more insulin injections, then their risk category went from moderate to high risk, yeah, in a bigger degree. Yeah, so insulin itself was the biggest, probably the major impact on the weightage of the risk scoring. So there are much more results that we could share at another opportunity, but due to this brief time. But lastly, just to show the user acceptance survey. So these 6 questions that we asked our doctors were, whether this new risk calculator provided them a more objective assessment compared to the previous that was used, and whether it was more comprehensive compared to the previously used, whether it could be used quickly. And we've already heard how if it was integrated into the electronic records that it can be computed within a minute or 2. We had a hard copy tool. We haven't really got it into a simple app. Yeah, and then whether the doctors were confident to recommend against fasting. This was an important question. Yeah? Once you have categorized the patient, could you go ahead then to confidently recommend against fasting? And whether with this, there are patients who are at risk were more willing to accept their advice against fasting, and subsequently whether they use the risk calculator again in the subsequent time. Yeah. So these were the results from the 20 healthcare professionals, which consisted of one consultant endocrinologist, trainees, physician trainees in endocrinology, and our medical officers. So we can appreciate that out of all, most would agree and strongly agree to all those questions. Yeah, but what the main question that actually we see that there is some results that are in the other direction is actually when there were high risk patients, were they willing to accept the advice of the healthcare professional against fasting? So here we do see that there were some who disagreed or were quite neutral, with that question. So there was still this hesitance or reluctance that we see of patients actually willing to accept the healthcare professional's advice once they've been categorized at an elevated risk of fasting. So that becomes still our challenge, and I think that points out that we need to have better education of patients so that they understand their risk and they better accept the advice and recommendations by the doctors. So as mentioned before, the doctors felt and strongly agreed that the new tool was objective and comprehensive, and 80% found it quite quick to administer, and almost absolutely felt they were quite confident recommending against fasting, but the issue was the patient accepting the decision. And all the respondents were keen to make this current risk calculator part of the standard of assessing risk for Ramadan. So in conclusion, we again mentioned that this new calculator is well accepted in this part of the world, in our country, in our small initial experience, and we hope to be able to use it in a more extensive way. It's well accepted, and however, we do have to face the barriers at the patient's end of how well they can accept the advice of against fasting when their risk categories are high. So thank you very much for listening and the opportunity to present. Thank you.